All right. So I wanted to go a little more in depth about shock and sepsis and really caring for that patient in the hospital or identifying it in the ER, early intervention, or on the floor. Okay. I feel like I might have not put enough into it in the last presentation, so I threw this together this morning. So a little bit more about shock and a little bit more about sepsis. If I can get it to change. It doesn't want to change. Oh, there, that's why. It's fancy. Okay, so when we look at it, we're looking at the concepts and those interrelated concepts that should be capitalized. So definitely, these are both all combined in a big hodgepodge. We have perfusion and infection, we have clotting problems, we have gas exchange problems, and then obviously the immunity problems when it comes to septic shock. What's important in the book brings it up quite a bit when you're looking at shock. And it doesn't really matter which type of shock, to be honest with you, but we're looking at more of the distributive shock when it comes to sepsis, just like we looked at distributive shock as it was associated with the anaphylactic response. But it's because it's where that blood is being distributed somewhere it shouldn't be, correct? That's where distributive comes into play. So we're looking at that mean arterial pressure. Mean arterial pressure is it's directly related to perfusion, correct? What impacts our mean arterial pressure? It's our total blood volume, our cardiac output, and then that size and integrity of the vascular bed, meaning where those, if you think about it down at the arterial and venous periphery, where it's very vascular, where we're perfusing oxygen and nutrients to our non-vital organs or to our vital organs, it's a very larger bed. Okay, so that total blood volume and that cardiac output are directly related to mean arterial pressure. So if our blood volume goes down and our cardiac output goes down, our mean arterial pressure is going to go down. But within distributive shock, we don't have a loss of blood volume per se, or the viscosity of the blood. So it's inversely related to the MAP. So as that vascular bed increases, our mean arterial pressure goes down. That vascular bed increasing is really, as we are seeing with distributive shock or sepsis, is the dilation of vascular beds, right? That from that inflammatory response. As that vascular bed decreases in size, let's say constriction, you're going to have an increase in that mean arterial pressure, and that's more in that compensatory stage, as well as our sympathetic nervous system, which always has some sympathetic tone in the smooth muscles of our arterioles that causes some constriction. So when that vascular bed is not functioning properly due to another causative agent, whether it's the inflammatory response, overwhelming sepsis, capillary leak, interstitial fluid, our fluid going into our interstitial spaces, fluid and electrolytes or anything else, we're going to have a dilation. We're going to have a decrease in our MAP. It's key to note because it's one of our first indicators. So the book has like 5 different pictures of this heart, but these are the 2 that are associated with distributive shock. So really, it's not that blood volume is lost. It isn't lost, but it's distributed into those interstitial spaces where we can't really measure it, right? There isn't an interstitial blood pressure. So it cannot perfuse organs when it's there. It increases capillary leak, that pooling of blood. And then our end result is what it says on the slide, is an increase in our mean arterial pressure. So this picture right here shows increased size of the capillary bed. So we're vasodilating out for whatever reason, or it's seeking in, or have capillary leak. The result is a decrease in our mean arterial pressure. And you have a decreased blood flow, obviously. You have decreased perfusion to organ tissues, vital organs. Here, it's constricting, the body's compensating, right? In early sepsis, we have a compensatory response. And that's where we need to catch these patients. So we have a decrease in the size of the capillary bed, because remember, our tissue, our muscles, our skin can go a longer time without oxygen. Those non-vital organs vice our vital organs. So the body is naturally going to, with the sympathetic nervous system, constrict, vasoconstrict that capillary bed, which results in an increase in our mean arterial pressure and that increase in blood flow and perfusion. So it's in that hyperdynamic state. So sepsis, as we know, and I've gone over this before, it's life-threatening organ dysfunction. And septic shock is a subset of sepsis, right? And SIRS, and multi-organ dysfunction syndrome. So septic shock's a subset of sepsis. It involves the circulatory, cellular, and metabolic abnormalities. And that when they come down to septic shock, the increased risk of morbidity is much greater over just sepsis alone, because you have other factors into play. So stages of shock are really important. And I think this comes into play with, it's earlier in the chapter, but it ties it all together. So we have the initial, the compensatory, progressive, and refractory stages. Right? The initial is it's compensatory mechanisms to return that systolic pressure to normal. It's that hyperdynamic state. Okay, it's not the compensatory state, but it's a hyperdynamic state. This is where we need to catch these patients a lot of times. Oxygen perfusion to the vital organs is maintained. All right, and it's hard to in this state. So it's really those subtle cues. We have cellular changes. We have an increased anaerobic metabolism at some tissue levels, which produces some lactic acid. So more in the periphery, the non-vital organs a little bit. Perfusion's being shifted at this point. So overall, our metabolism is still aerobic, not using anaerobic production, not producing a lot of lactic acid, but it's starting to. And then the compensation, our body starts to compensate by increasing heart rate, and then that vascular bed is constricting a little. So that's the initial stage. Really subtle cues on your patients during the initial stage. Now, when you get into the compensatory stage, you start to see a decline in your mean arterial pressure from the baseline. Remember, we all might have a different mean arterial pressure. And the goal is to keep it greater than 65, and that's part of the Surviving Sepsis campaign, I think, in general, just to keep oxygen and tissue perfusion to the oxygen tissue perfusion to the vital organs. So during the compensatory state, our kidney and hormonal compensatory mechanisms are activated. And this is why sometimes when you draw, patients end up with adrenal insufficiency due to the HPA system being activated and overtasked and not functioning properly due to inflammatory cytokines. But your kidney and hormonal compensatory mechanisms are activated. We have a continued decrease in MAP, which what does that do? It triggers your renin, angiotensin, aldosterone system. So if it triggers renin production and ADH and your aldosterone, then epinephrine and norepinephrine to start that kidney compensation with that continued decreased MAP. So what does that do? It reabsorbs sodium, so our sodium increases. Our urine output decreases as the end result of sodium and water, right? Water follows sodium. Our blood vessels constriction occurs. Antidiuretic hormone increases water absorption in the kidney, which further decreases urine output. And then our blood vessels actually constrict. And so, like I said a few minutes ago, to our skin and less vital tissues, sometimes the book mentions it as non-vital, because they can last longer without perfusion and oxygenation, which is that trigger for anaerobic metabolism and some lactic acid buildup. But that blood vessel constriction is occurring in that vascular bed to increase cardiac output. So these actions compensate to maintain fluid in the central circulation to those vital organs, the kidney, the brain, the lungs, the heart, the liver, okay? Some of the cues we have to identify here. This is where early intervention, this is where a rapid response team comes into play. This is where the MUSE comes into play. Even the SOFA, the SOFA, sequential organ function. I know I said that wrong, but anaerobic metabolism. So if you were to happen to draw an ABG, which we don't typically do on the floor unless they have a reason to, right? They're showing signs and symptoms of poor perfusion, oxygenation, but you're going to see acidosis in the blood, okay? And an increase to potassium. Why are you going to see an increase to potassium? Well, with that vascular leak, the cells are rupturing, correct? Causing release of microorganisms and damage and those electrolytes. The subjective changes, the patient might have a little more anxiety, a little anxious, and they're thirsty, but because they have decreased urine output, they have a decrease in volume. Even though they appear to be in a hyperdynamic state that is compensating, they still have an increased need for thirst and volume because they're leaking into their interstitial spaces. So those objective changes, which are what we needed to see. restlessness, right? Tachycardia or increased respiratory rate. Increased heart rate, increased respiratory rate, that decrease in urine output. Their systolic blood pressure starts to fall more, it's dropping, and their diastolic pressure starts to increase. So they have that narrowed pulse pressure between systolic and diastolic. So there's less time to actually improve circulation. The body doesn't have the fill-in pressure times. Their extremities become cool, and their oxygen saturations start to decrease. These are those subtle signs. These are all, if you look at them, are signs of RRT. Calling your rapid response team, calling your MERT team, whatever the hospital calls it. And then progressive stage. So now your mean arterial pressure is sustained more, 20 millimeters of mercury less from that baseline. Now the compensation cannot deliver sufficient oxygen now to your vital organs. So those vital organs become hypoxic. With hypoxia, what happens? We have the production, it's anaerobic metabolism, okay? Those non-vital organs, the less vital, the skin, muscles, they develop anoxia and ischemia. So tissue death, lack of oxygen and tissue death ultimately. Subjective changes due to the fact that they have decreased perfusion, the patient can have a sense of impending doom. They feel like something bad's going to happen. They start to get confused, right? Lack of oxygen delivery, lack of perfusion to the brain, and their thirst increases even more. So with objective changes, these are rapidly occurring. So, they have a weak pulse, they have low blood pressure, they're cyanotic, oral mucosis, and the nail beds are blue. Cyanosis, signs of poor perfusion. They're cool, moist skin, no urine, anuria. 5 to 20% decrease in O2 sat. So if they came in with a 96, they could be down to 76. Obviously, intubation is typically going to occur in these patients. It does occur. Their blood pH is even lower. They're more acidic. So they have a rising lactic acid levels at this point and potassium levels as well. And honestly, procalcitonin levels probably too if they were to draw on. It's a life-threatening emergency, the progressive stage, right? Our vital organs can only tolerate hypoxia for a short amount of time. Think about your heart with a myocardial infarction, minutes. You have multi-organ dysfunction syndrome occurs. Once 2 or more organs, you're in septic shock. It's permanent damage. You have to have immediate interventions are needed to reverse at this stage. So it can be saved, life usually can be saved if conditions causing it are corrected. Now this is where our 1-hour bundle comes. At the onset of the progressive stage, ideally we catch it before the progressive stage. But often when your patients present to the emergency room, they're in their progressive stage, right? So now you have to initiate that 1-hour bundle, because they don't come to the hospital unless they're symptomatic many times. So shock, the refractory, and MODS. So there's been too much cell death and tissue damage. Let's say they were sitting at home for a really long time, or we just didn't catch it. Or we could not treat it and prevent it. It's not always that you don't catch it and intervene. Sometimes the body's overwhelming infection based off what the source of infection is more than our interventions can manage or treat. So the vital organs have extensive damage. They don't respond effectively to interventions, fluid, antibiotics, and the shock continues. So there's so much damage that the metabolites and enzymes that are released damage vital organs. The damage to the vital organs continues. So those metabolites and enzymes are released with cell damage, with anaerobic metabolism, despite interventions. So multiple organ dysfunction syndrome, cells are caused by the massive, that damage to the organs is caused by the massive release of that toxic metabolites as stated above and those enzymes. So it's a vicious cycle. The more the dead cells open, the more they release metabolites. The liver, heart, brain, and kidney functions are lost first. They have microthrombi. This is where heparin gets involved because that further blocks tissue perfusion. Their subjective changes, well, they have a loss of consciousness. You can find now non-palpable pulses in the extremities, cold and dusky extremities because of the vasoconstriction of the natural from epinephrine, norepinephrine. And at this point, you probably have your patients on, dopamine or dobutamine or Levophed, or, any other vasoactive medication. They have really slow, shallow respirations, unmeasurable O2 saturation due to the extremity being cold or the lack of oxygen being delivered to the periphery, to those non-vital organs. So at this point, therapy, including that fluid replacement, is not effective. We're in the refractory stage. So the Surviving Sepsis campaign, which you should have gone to when you did your case study, really has been around for a long time. But it's improved over the years, over history, over statistics and data and compiling information. So like the book said, there used to be the 3-hour bundle and 6, it's now put into the 1. Remember, by the time your patients come to the hospital, they're already showing signs and symptoms of sepsis typically. So this came directly from the Surviving Sepsis campaign organization. There's numerous types. Each hospital creates their own bundle. Okay, but this is a great, easily way. This is what people normally implement, something similar to this as their screening tool. As you can see, you're looking, do they have a reason for infection? Is there suggested? Do they have meningitis? Do they have a UTI? Do they have a wound? Right? Are they diabetic? And then any of the two of the following, any two of the following signs and symptoms of infection, both present and new to the patient, any of them. Are they febrile? Are they cold? Do they have a change in mental status? Are they tachypnic and tachycardic? Are their white blood cells high or low? Are they hyperglycemic? With sepsis and infection and stress, increases the production of cortisol. So, all right, now you're going to obtain a lactic acid and blood culture, right? Along with all these other things. And then typically you're going to do a UA and everything else at the physician's discretion. But typically, if you're going to draw blood cultures, you're going to draw them from any source you have, whether it's a line, a Foley catheter, let's say they come from a skilled care facility, but you're going to get a urinalysis to see what the source of infection is, right? And then organ dysfunction criteria is listed below that. So at this point, you have some organ dysfunction. If your creatinine's elevated, if they don't have a baseline problem with their kidneys, right? Bilirubin from their liver, right? Let's see. So you're going to document and time this, stamp it. So the Surviving Sepsis Campaign Hour 1 bundle, these are the elements. So we measure lactate level. You obtain those blood cultures. This is all within an hour of presentation or when you identify these symptoms. Administer broadband spectrum antibiotics until those cultures come back, and you can actually they can treat with the proper antibiotic. They're going to get fluids, lactated ringer, right? For anything for either crystalloids for anything for hypotension or a lactate level that's greater than 4 millimoles. Vasopressors also, if their mean arterial pressure is less than 65 after fluid resuscitation, okay? Because all that's going to do is decrease perfusion to your extremities, again, your non-vital organs. And then you're going to remeasure the lactate level. So if it's elevated, just greater than 2, whereas in theory, you're not going to start fluids if they're not hypotensive and their lactate level's 2, you're going to remeasure it because the likelihood is something's brewing, right? That's the 1 hour bundle. So, some of the hallmark signs of diagnosing sepsis, you have that rising serum procalcitonin level. So procalcitonin is really a prohormone, right? Produced in the thyroid gland. And it's not secreted out into the body typically, but during inflammatory response, cytokines are released, tumor necrosis factor A is released, procalcitonin is secreted into and activated into the bloodstream, adheres to those monocytes. So what's known about it is PCT, procalcitonin levels, are an indicator of a bacterial infection. And often providers will trend the procalcitonin level to help delineate or depict, I guess, their antibiotic course of treatment. Okay. What else can I say about it? That's probably about it with that. They have increased serum lactate levels. That's a sign. You can have normal or low white blood cells with a shift to the left. What's a shift to the left? The increased number of immature white blood cells. So segmented neutrophils are your mature white blood cells. But if your body's trying, your bone marrow is producing, try to ward off infection, fight off that infection, it doesn't have time for those neutrophils to mature. So it's called a left shift. And then, presence of bacteria in the blood is not always going to be there, but it also often can take 24 to 48 hours to grow out on that blood culture what it is. Okay. What else is there? I think that's it. So we need to identify the problem. What is the source of infection? Right? Correct and treat it. Is it a UTI? Is it from a wound? Is it from a diabetic foot ulcer that was amputated and now is not being treated well? Is it from a catheter that we have placed in, like a central line? Is it from a dialysis catheter? So there's lots of different sources. So when you see a patient that presents to you or they're in the hospital and they start to deteriorate, if every source of every access device in a patient, whether it's a ventilator, whether it's a central line, whether it's an IV, whether it's a catheter, whether it's a dialysis catheter, hemodialysis catheter, portacath, will have blood cultures drawn from it. They'll remove it if that's the source. Often that will help treat it. The 1 hour bundle started, we give oxygen. Drug therapy is, for sepsis interventions. For sepsis, you think of vasopressors, right? Fluids, antibiotics. For hyperglycemia, due to stress on the body and overproduction, they're going to be on insulin. You anticipate insulin to be either infused or sliding scale. They're going to have clotting problems initially during certain stages when the microthrombi are being formed during that inflammatory response. And they're going to require heparin therapy to try and save the platelet production. So if, ultimately we might end up giving blood products, platelets, fibrinogen, any clotting factors potentially if they're depleted. And then they can end up with adrenal sufficiency as well. It's common. So the HPA axis is affected. It's infected after the initial inflammatory response. The sepsis is activated. So there's that endogenous release of cortisol. So, they're going to end up needing corticosteroids. So, and that's really it. I just wanted to make sure